Is it possible to stay small and independent in this environment?
For sure. Well, definitely the answer is yes, but it's a qualified yes.
Rockett, thank you so much for coming on the Scope Forward show. It's not every day that I get to talk to somebody who has founded a company on his own name. So you are the principal of Rockett Healthcare Strategies, and you have worked for a long time with gastroenterologists and the GI space. So I'm really looking forward to our conversation today.
Great. It's a pleasure to be here, Praveen. I've admired your company and the growth of your organization over the last few years, and you and I have talked from time to time, but it's been great getting acquainted with you.
Rock, you've been in the GI space for a long time. How did you get involved with gastroenterology?
Right. Praveen, I've been involved with a gastroenterologist for about 15 or 20 years. I initially became involved through a small company that I was running that was doing accreditation consulting. We had a relationship with the accreditation agencies with the Joint Commission. So I was approached by the Joint Commission and they said, Blue Cross has some concerns about offices and about office-based procedures, and would you be able to talk to them? And so I started talking with Blue Cross, and out of that developed a negotiated arrangement so the physicians, gastroenterologists, could be reimbursed at a higher rate for doing procedures in their offices, provided that they became accredited. So I provided the accreditation consulting, Blue Cross provided the incentive. It was a nice little package deal, a win-win for the members, for Rockett Healthcare, and for the gastroenterologist. Mm-hmm. So that was really what kicked things off for me.
How has GI changed over these last couple of decades from your lens?
What I've seen over the last 15 to 20 years is, number one is consolidation. I see that they're also being able to, look at different revenue sources, because while the consolidation is going on, there's also the downward pressure on their charges and on their reimbursement. And so with that downward pressure, then they have to come up with, more creative solutions. And so developing additional revenue strategies is something I've been very much involved with, and I've helped the gastroenterologist in that regard.
What do you think of this wave of consolidation that has swept gastroenterology as a space?
I guess ultimately I'm not a big fan of it, but the consolidation obviously leads to bigger and bigger organizations, and bigger organizations are tougher to deal with, more difficult for patients to navigate, and so you start losing some of that age-old physician-patient relationship. It's a fact of life. It's here to stay. It's not going away, and it will sweep up large segments and large chunks of the entire healthcare industry, but not the whole thing. So that's my view.
So when you say not the whole thing, let's talk about that segment that does not want to consolidate and wants to stay small and independent. So I want to start by asking you, is that even possible, given this massive pressure coming in from the health system side, because the health systems are consolidating and they're locking in referral networks, and then the other practices, maybe in a region, they've taken PE or joining a PE platform or plan to, they might be consolidating, or hospitals are acquiring physician practices. That trend is happening. And again, like you said, the insurance reimbursement is on the decline. So given all these changes, is it still possible? And I'm sure many in the audience are interested in this question. Is it possible to stay small and independent in this environment? And if If the answer is yes, I already have a follow-up of how.
For sure. Well, definitely the answer is yes, but it's a qualified yes. Okay, so it's a qualified yes. You can stay small. You can stay independent. You can be in control of your own not only your own destiny, but be in control of your own practice patterns and your own approach to patients and patient care and so forth. And in some situations with these consolidated and larger groups, they get very very focused on production and productivity and so forth. They kind of get obsessed with that. I've had clients of mine who just rebelled against that and say, I want to practice the way I want to practice. I want to do as many procedures as I want to do. I want to have that control that a physician should have. And it depends upon your market, depends upon where your group is, depends upon your relationships within that market, your referral network and so forth. Some others have come to me and said, well, if I go off and do this and set up office endoscopy suite, the hospital is going to crush me. And I said, well, that's certainly possible, and maybe this is not for you. So it's not for everybody, but it definitely is a strong and viable solution.
So who is it for? In what kind of environments is such a model possible? And when you say that, again, I'm saying this in my own words, but helping physicians or gastroenterologists diversify and add revenue streams, how can they do that? What are those strategies that they can deploy?
Well, so the strategies are the strategies that the consolidated groups, employ as well. So there are arrangements where the gastroenterologist can share in the pathology revenue. That are totally legal, totally within the constraints of the regulations. And there's one model is called a TCPC model. There's other kinds of arrangements where a group can work with a local path lab or a path lab anywhere in the country for that matter, and they can participate in the pathology revenue. Likewise, on the anesthesia piece can be part of the revenue solution because you either hire your own MD anesthesiologist, hire your own CRNAs, bill and collect for them. There's other models where the mobile anesthesia group will come into your office and you will do the work with them, and then they will provide the nursing services. They'll provide the recovery room nurse or nurses. If a recovery room nurse is $80,000 a year, for instance, that's a pretty significant chunk. So I would say, to anybody interested in being on their own or going out on their own or having a small group and on an independent basis, you look at your professional fees that's coming to you for your practice. You look at other revenue sources, and principally those are anesthesia and pathology. There are some other smaller items that colon prep and so forth, but yeah, that's in kind of in a nutshell. That's how it can work.
Mm-hmm. Doesn't some of this require investments or money? And some doctors may ask, where would that come from?
Exactly. Yeah, you got to have money to make money, right? So it does require an investment. So what I would do with a gastroenterology group, they can come to me, or they can go to their, they can go to an accountant or someone to say, hey, how much is this going to cost, and how much am I going to get from it? So you kind of develop a pro forma. You develop a pro forma much like the surgery center management companies would develop. And so you look at those costs of the build out, the design, the build out, the equipment, the staff, the cost of getting accredited, and put all of that together, and that's the cost. And over how many years can we amortize those costs? Can we lease equipment, do certain things like that? So that's the first component is the expense side. The second side is what is the reimbursement going to be? Are the payers going to reimburse me more for doing the procedure in the office versus and there is a certain trend in that regard that's a very positive trend. So, and I had a conversation just yesterday afternoon with a vice president of a leading Blue Cross organization. And they just as of this past January, 2 months ago, increased the reimbursement for office-based procedures by 15%. Well, if you're a gastroenterologist and you're already getting $700 or $800 for an office-based procedure, then that's another 15% on top of that. You could be a podiatrist. You could be a urologist. There are several different specialties that applies to. The payer organizations, and principally Blue Cross, are seeing that they have to do something to counter the consolidation efforts, right? Because they're losing leverage. When the payer is, still the same size the payer is, but the providers get larger and larger, then the payer is losing leverage. So they have to do something to strengthen their position. There are regulations, right? The certificate of need regulations, which dampen or prohibit the development of surgery centers in roughly half of the states of the US. Illinois is one, Massachusetts, North Carolina, lots of East Coast states, a couple of West Coast states. So the payers are looking at different strategies. In some cases, the payer will pay the gastroenterologist equivalent to a facility fee. They will say, we will pay you as if you're a licensed surgery center. We know you can't be because of the regulations in our state.
What I keep learning is that the insurances are getting so big that even some of the largest physician groups are finding it difficult to negotiate with them and improve contracts. So if that is the case for these large groups, then if somebody decides to stay small, could they ever expect to get better reimbursements or negotiate with these insurances? Will they even come to the negotiating table?
Yeah. So very good point. Very good point, Praveen. Individual, a small group negotiating with Blue Cross, forget it. That's not really going to be too effective. I think what you have to be aware of are what are the trends? What are the reimbursement trends by the being invoked by the payers? And so, and it's literally on a state-by-state basis. The Blue Cross of Illinois pays for roughly 200,000 endoscopy procedures per year. And then that if they're paying a surgery center or a hospital outpatient department, an average of $1,500 to $2,000, then it's hundreds of millions. It's like $300 million a year. And so it's not heart surgery, it's not knee replacement, it's not big ticket items, but it's high volume of a relatively low cost procedure. And so Blue Cross is incented, they are motivated to address that issue and how can they impact it. And I think the pandemic is probably inspiring that as well, or contributing to that. Nobody wants to go to a hospital now unless they absolutely have to. So to have a colonoscopy done in a hospital, this doesn't make much sense. Mm-hmm. So it needs to be done in a surgery center. Oh, our state is a certificate of need state. We don't have many surgery centers. Okay, you got to come up with another solution, and that's where this office-based solution is effective. So there are favorable market conditions for office-based procedures and for independent practices to maintain and grow and sustain themselves. And then there are certainly unfavorable market conditions, and that people have to be aware of that. And that's something that I try to keep my finger on the pulse of, so that's part of the value that I bring to the table.
The gastroenterologists who are deciding to stay small and independent, how are they working out their relationships with the regional or local hospital or health system? Do they have any control at all? If so, how?
Let's take Chicago for an example. Let's take the Advocate Health System, for example. So, within a very large organization like Advocate, I don't know, 14 or more hospitals, thousands of physicians, many of those physicians are employees, right? They're employees of that organization. A kind of an equal number, a couple of thousand physicians are what they call advocate physician partners. So they are contracted through their arrangements with the carriers, are contracted through the through the advocate system and the advocate umbrella, but they're not constrained by that. They're not employees of that, so they still have this independence, and that can work. And there's age-old examples from I don't know, 20 or more years ago in Virginia with Dr. Irving Pike, and negotiating an arrangement with the system there to say, look, this is what we're going to do. We're going to create, our group is going to do office-based procedures. That doesn't mean we're going to cut out the hospital entirely, because we're still going to make referrals to the hospital. There's still the higher level cases, the cancer cases, whatnot, that are going to get referred to the hospital. So, it's not a total sum game. There are arrangements where everybody can share in a piece of the pie. Maybe it's not as big a piece of the pie as they used to have, but they still get a piece of the pie.
Mm-hmm. What's your view on gastroenterology for the next 5 years, 10 years, maybe even longer? How do you see the space from a business standpoint evolve?
So I think technology is going to, erode the position of gastroenterologist. I said something to a prominent gastroenterologist in Chicago a couple of years ago about doing a colonoscopy, and he looked at me and he said, "A monkey can do a colonoscopy." So don't get worried about the difficulty involved in doing a colonoscopy. So I said, maybe somewhat of an exaggeration, but nevertheless, there are those issues. So the technology is a big driver. This consolidation, it's interesting to me, because I see the pros and cons of consolidation, and once consolidated, do the doctors stay in those groups? And there's some indications that there definitely is a segment of people who, once they've gone through that whole consolidation process, they say, you know what, this is not what I thought it was going to be, and I'm out. I'm going to exit. And maybe it's the more affluent. Maybe it's the more affluent who will be able to preserve their independent physician practice. They'll still have that relationship with their independent small physician practices, and unequal, but it's a reality.
Rock, thank you so much for this conversation. Any final words before we close?
I very much appreciate your time today and spending this time with you, Praveen. It's been a good experience, and I hope I can contribute something to help the gastroenterology specialty and the individual physicians who are looking for what's the right fit, what's the right career fit for them within their specialty.
Thank you.
You.
Thank you so much.